Good evening to seniors, teachers, dear friends and colleagues. At this outset, I should first thank GKN sir for giving me this opportunity to present this interesting topic. We'll have a quick recap of what we had actually presented on 25th of August 2025. It was an introduction to this topic. So, as mentioned by sir, this term was actually coined by International Kidney and Monoclonal Gammopathy Research Group in 2012. And this term applies to any B cell or a plasma cell clonal lymphoproliferation with both of the following characteristics. Like with one or more kidney lesions that are related to the produced immunoglobulin, and the underlying B cell or plasma cell clone does not cause tumor complication or meet current criteria for any hematological criteria for specific therapy. So usually it goes from monoclonal gammopathy of unknown significance where the tumor burden is not met. The plasma cells are less than 10% in the bone marrow. Monoclonal spike might be seen, but it is less than 3 grams and there's no end organ involvement. But it evolves to smoldering myeloma, where the monoclonal protein might be more than 3 grams and the tumor burden is met, but there is no end organ involvement. But in multiple myeloma, where the patient deserves treatment, has the tumor burden of more than 10% plasma cells and CRAB-related features. So where is our MGRS? It is in between MGUS and smoldering myeloma, that is MGUS with renal involvement or smoldering myeloma with renal involvement. That means it doesn't require treatment as a myeloma, but as the patient is having renal involvement, patient should be treated. So with that, let's go to pole 1.
So I think we'll start off with the cases on each pole because it's very interesting to deal with it that way. So this is a very interesting lady, 53-year-old lady with dyspeptic symptoms, antral gastritis. She was diagnosed with hypertension with dyslipidemia and LVH, so it's chronic hypertension. The serum creatinine was initially 1.4 but then became 1.1. She had a renal stone disease and subsequently found to have uncontrolled hypertension. The urine PC ratio you can see in August 2024 was 0.76 but subsequently dropped June 25 to about 0.2. And then she had a small erythropoiesis protein, monoclonal protein. It's about 0.68 gram, and you can see that fits into the MGUS band of what you have just heard. And immunofluorescence showed an IgG and lambda. So both IgG as well as a lambda IgG, such as a clonal lambda clone. PET scan was negative. Bone marrow showed more than 30% monoclonal plasma cells. And proteinuria resolved with control of hypertension, renal function stable for the past. So what will be the diagnosis of this patient? So you can see that there was some proteinuria, but that is resolved. There was some hypertension which has been controlled. Renal function was abnormal, but that is now normal. And the patient has can you just launch the poll? There has a BM, bone marrow, more than 30% monoclonal plasma cells. So which should be this? That's the thing. So you can start the poll now. So is it an MGS, an MGRS, a smoldering myeloma, or is it a multiple myeloma? I think if enough people have voted, you can stop the poll. And so I can see the results that many people have guessed smoldering myeloma, which seems to be the most appropriate response here. But I agree, this is a case where you have to listen closely to the clinical details. So I'll ask our expert, Dr. Shinto, to comment on this. Dr. Shinto, you're there?
Yeah.
Yes.
Yeah, I think I'm audible right now, right?
Yeah, you're audible. Yeah.
Okay. Yeah, thank you for inviting me because the renal-related hematological problems are always me and Dr. Jaymeena usually discuss this case on a day-to-day basis. So with this case, I think I will discuss the case as she is for me 53 is young because in a transplant point of view. So female presenting with dyspeptic symptoms, but she has some comorbidities. I think diabetes is not mentioned. A small M band is there and creatinine fairly okay. And urine PC ratio 0.76. So the IFE, that is immunofixation wise, there is it says it's clonal IgG lambda because SPEP can occur as a MGUS in any elderly. It can stay on for many years. So here we know that it is a monoclonal gammopathy, IgG lambda type. Kappa lambda, that is the light chains are fairly okay. No crab wise, no other symptoms. No crab criteria, right? So it fits into the option 3, smoldering myeloma, because for that either there should be a protein or a bone marrow criteria, that is more than 10% bone marrow or a protein more than 3 gram per deciliter without crab, or nowadays we have slim criteria also, that is the light chains, MRI wise the lytic lesions, and bone marrow more than 60 is definitely myeloma. So it best fit is smoldering myeloma. We might ask for a biopsy also, because if smoldering myeloma we don't usually treat, but if we have to treat, we might even ask more, that is a renal biopsy, if after discussion with the nephrology people, because MGRS, that's what we are discussing now, right? So that will be my call.
I think that's probably a very good reason to say so, smoldering myeloma. So at this point of time, I'm not sure renal biopsy will be helpful. But anyway, we have to wait and see how this evolves over time, because many of these will evolve into myeloma in future. So that's also a problem we have. But we'll go on, because we'll have a poll coming up soon.
Because 30% is something which we should be watching out very closely, because 30%, it's bone marrow is always how we define, because it's a focal area. The needle can go 1 millimeter here and there. It can be 50% there, 20% here. So we can't poke everywhere. So PET can't give you the diffuse infiltrative pattern. So 30, I'll be very skeptical. I'll be having a very close watch on her.
Yeah, probably next time we do it, maybe a 60% may fit the criteria for myeloma also.
Yeah.
Okay, I think go ahead, Dr. Jaymeena.
One more thing, the PET is not done here. PET is negative.
PET is done, negative.
Yeah.
Okay.
So, okay. So this is actually a spectrum of disease. This monoclonal gammopathies are a spectrum of disease. It starts as MGUS, goes to smoldering, and then myeloma defining illness takes place. One good thing about MGRS is that you can actually detect these MGUS smoldering myeloma quite early because of the renal involvement. They either present as renal failure, proteinuria, hematuria. So now what happens is that we can actually diagnose these patients very early and give them the necessary treatment so that these patients actually don't progress to myeloma proper, just because they had a renal involvement early, at the early stages. There is one good thing about MGRS. And now let's go to the poll 2.
Yeah, poll 2 is also just another, now we are entering into the kidney. So it's a 55-year-old lady presenting with nephrotic syndrome and a creatinine of 1.7. So she's got proteinuria, she's got an abnormal renal function, and she's got a monoclonal protein 0.14 gram per deciliter. And immunofixation showed bands on IgG and kappa. So you can see it's a kappa region. So the free light assay was within normal limits, so that was not showing up on the free light chains. Renal biopsy suggested of minimal change disease. The PET showed no abnormal uptake. Bone marrow biopsy is within normal limits. So what's the next ideal investigation done on diagnosis? So you can see here that there is a abnormal band, but it is a very small M band, and the free light chains are not showing up. But there is definitely a nephrotic syndrome and a renal involvement. So the renal involvement is very outsized, but the bone marrow involvement doesn't seem very great. So what should be done next? You do a bone marrow flow cytometry or an electron microscopy. Can you launch the poll? Urine immunofixation or an anti-PLA2R antibody? What would be the next poll, please? Poll number 2. Yes, here it is. So you can vote for this. You see that the features of myeloma don't seem very impressive here. Yes, so you can stop the poll and you can launch the answers. Yes, I think most people have gone for electron microscopy. So this one I will just ask Jaymeena to comment on this, what you should do in this patient.
Okay, sir. Actually, the MGRS associated renal disease is basically based on classification by electron microscopic examination of renal biopsy. Like in electron microscopy, we can actually make out non-organized or organized deposits. Non-organized deposits are basically immunoglobulin or non-immunoglobulin type. In non-immunoglobulin type, you get the C3GN. So in an elderly patient presenting with C3GN, we have to definitely work up for monoclonal gammopathy, either by doing a paraffin IF on the renal tissue to unmask the immunoglobulin. We have to do a size and we have to do a bone marrow in such patients. And if it is a pure immunoglobulin deposit, it could be monoclonal immunoglobulin deposition disease or a PGN-MID. In organized deposits, we have three types: fibrillar, immunotactoid or tubular, or crystalline deposits. Fibrillar includes amyloidosis, fibrillary GN. Tubular deposits are cryo or immunotactoid glomerulonephritis. And crystalline deposits include light chain proximal tubulopathy, crystal storing histiocytosis, or now there's a new entity called crystalloglobulinic glomerulonephritis. So with that, let's move to the pole 3.
Yeah. So this is a same patient which you can see here. And then since all of you have just electron microscopy, that's what they did. And this showed diffuse effacement of food process, no deposits. So no, either organized or non-organized. Bone marrow flow cytometry and immunophenotyping are all sensitive polyclonal plasmosis. So what will be the final diagnosis? So I can launch the poll now. Is it an MGRS with MCD? Is it an MGRS with MCD? It's a smoldering myeloma with MCD or an MGRS with membranous nephropathy. So this is the poll. So please launch the poll. Yeah, here it is. So what do you think it is? So, okay, you can answer us, please. So I think the house is divided between MGS with MCD and MGR with MCD. So since that is a hematological problem, whether it's MGRS or MGUS, I think I should ask Dr. Shinto to comment on that.
Yeah. So I'll go with the first one, MGUS. Because basically we all agree that MGRS is a clone, either it's a plasma or B cell clone, because they are producing problematic proteins, whichever small amount it is, and it is screwing up the kidney by whatever deposits they make, right? So MGUS is, there could be an MGUS which can stay for many years. It may not even progress to, it is like 1% per 10 years or, so the incidence is very low. Any elderly patients, they can have an MGUS. Okay, so in this case, we couldn't connect that M protein to a clone in either a B cell or a plasma cell clone. So unless this flow cytometry, everything they say, and even there is no defined deposits which we could demonstrate in the EM also. So probably I would call this a separate MGUS and MCD separate.
So I think I also would agree with Dr. Shinto that this is an MGUS with MCD because there is not sufficient evidence to make a diagnosis of MGRS. And the key point here, which I would like to emphasize, is that it is very important to do a biopsy in these patients. Otherwise, you will think that this is an MGRS, the whole thing, but now it turns out it's a minimal change. You have to treat the minimal change disease. You don't have to treat it. And the another key point is that in these patients, you need electron microscopy because that is what is going to give you the final clinching diagnosis. So both the biopsy and EM are important in when you are suspecting an MGRS in a patient with renal syndrome. Over to you, Jaymeena.
Okay.
I think we are having another poll immediately.
So next is poll 4.
Yeah. So this poll is also an interesting one. So it's a 51-year-old male with hypothyroidism, dyslipidemia, recently diagnosed with diabetes, and again presenting nephrotic syndrome, normal serum creatinine, bland sediments in the urine, and renal biopsy shows a mesangial expansion by fibrillary material and mesangial deposits of C3 and lambda mesangial. So both lambda and C3, IgG lambda and IgG, I don't know, it's not mentioned IgG, then lambda and C3. And the FLC difference is more than 80. So that means, and the FLC ratio is 0.21. So that's a high amount of free light chains also here. The bone marrow is normal limits and electron microscopic presence of fibrils. So diagnosis in our EM could be all of these except. So can you launch the poll? So there is definitely fibrillary material. So what would be the odd one out which cannot be the diagnosis here? I think that's a reasonably simple one. So I think we can stop the poll and launch the results. Yes, I think audience is quite good at this now. So they have got PJ now ID very easily. I think Jaymeena will continue with this and show the electron microscopy.
Okay. So basically, the thing what we look for in electron microscopy is that in electron microscopy is fibrillar material. The fibrillar material is either amyloid or fibrillary gene. Fibrillary gene at times can be even congophilic. So we have to subject these congophilic patients also to electron microscopy to differentiate. In electron microscopy, it is basically the size or the diameter of the fibrils. It's 8 to 12 nanometers in AL amyloidosis, whereas 15 to 25 nanometers in fibrillary gene. Whereas in tubular, if you get a microtubular arrangement like this, it is basically either cryo or immunotactoid. And that also has got a difference in the diameter. And you can get needle-shaped or rhomboid-shaped crystalline structures in light chain proximal tubulopathy. So let's move to the treatment of MGRS. What is the basic target of treating MGRS? It's basically to reverse and stabilize the existing kidney damage or prevent further kidney injury. Basically, it is determined by the pathological type of kidney injury and the nature of clone. It can either be plasma cell clone, B cell clone, or a lymphoplasmacytic clone, which is producing the nephrotoxic monoclonal immunoglobulin. So, the evaluation of patients with confirmed MGRS is that if you see a monoclonal deposit in kidney, it means that there is an existence of a plasma cell, B cell, or lymphoplasmacytic clone. So, the subsequent evaluation is directed towards the characterizing this clone. So, we actually go with the monoclonal protein testing and bone marrow aspirate and biopsy. So, the monoclonal protein testing includes serum protein electrophoresis and immune fixation, 24-hour urine protein electrophoresis and immune fixation, and the serum-free light chain assay. And we actually might require the combination of these tests to maximize the sensitivity in detecting monoclonal protein, particularly if the patient has got very small clones. And one important thing is that once you get a monoclonal protein, it should match with the monoclonal protein that is being deposited in the kidney. So identification of serum and monoclonal protein, if present, is important because we have to monitor the response to therapy as well. So the bone marrow aspirate doesn't stop with light microscopy alone. It has to be subjected to immunohistochemistry and flow cytometry for the surface and intracellular markers of plasma and B cells. And staining of kappa and lambda chain is also being performed because it should show the same light chain restriction as that of monoclonal deposits in kidney. Apart from that, this patient is being subjected to cytogenetics and FISH, which helps in directing therapy. So, in identifying the clone, sometimes we might also have to undergo flow cytometry of peripheral B cells, peripheral blood lymphocytes, to detect very small clones of CLL and monoclonal B cell lymphocytosis. All these have very small clones. It will be in the peripheral blood. And in addition, we might have to subject the patient to CT scan of chest, abdomen, pelvis, and FDG PET in search of a B cell clone. So, sometimes we might never get a clone with whatever we do. So, in that case, we have to see the protein what we have got. If it is an IgM protein, it is most likely because of B cell or a plasmacytic clone. If it is a non-IgM protein, it is considered because of plasma cell clone. So what are the chemotherapeutic agents we have in our armamentarium? It's basically protease inhibitors like bortezomib or carfilzomib, or monoclonal antibodies like rituximab, daratumab, alkylating agents like cyclophosphamide, bendamustine, melphalan, immunomodulatory agents like thalidomide, lenalidomide, and pomalidomide, and glucocorticoids, prednisolone, dexamethasone. In some patients with amyloidosis or MIDD, even autologous stem cell transplantation is a strategy. So let us see case by case how we have managed MGRS. In patient 1, he is actually a 65-year-old man who was a diagnosed case of hypertrophic cardiomyopathy presented with frothing of urine and pedal edema of 2 months duration. System-wise, he was normal, and urine protein showed 3 plus proteinuria, and urine protein creatinine ratio was 5.5 gram per gram. And he had, on further evaluation, his creatinine was 1.2, he had normal calcium, hemoglobin was normal, and ESR was also normal. In liver function test showed decreased albumin and total cholesterol was elevated. So the clinical diagnosis was nephrotic range proteinuria with normal renal function, and he was normotensive, and he had features of hypertrophic non-obstructive cardiomyopathy. So with that, we subjected him to renal biopsy, which actually showed a mesangial proliferation, mild mesangial proliferation with monoclonal deposits. Lambda chain was positive in these mesangial proliferating areas. So this patient underwent bone marrow examination, which showed aspirate showed only 2% plasma cells, and bone marrow biopsy was within normal limits. So monoclonal protein in serum was evaluated. SPEP showed M band of 0.51 grams, a very small M band, and immunofixation showed IgA and lambda was fixing, and free light chain assay showed an elevated lambda. Differential lambda to kappa was more than 100, and the ratio was 0.11. So we subjected the patient to electron microscopy, which showed fibrillar material in the mesangium, non-branding fibrillar material in the mesangium, and it was about 9 to 12 nanometers, and it was consistent with renal deposits of amyloid fibrils. So the final diagnosis of the patient was AL amyloidosis with renal involvement. There was no evidence of plasma cell clone in bone marrow, and lambda monoclonal band in serum was present, and this is typical of MGRS. So let's launch the pole 5.
Pole 5, I think, is an important thing because of all the MGRS that we see, the most common AL amyloidosis. So how do we predict the prognosis in these patients? Is it dependent on stage of renal failure, the quantity of proteinuria, the extent of cardiac involvement, or the hepatic involvement? So launch the poll, please. I think, yeah. So which one would you go for? So is it the renal, cardiac, or hepatic? I think you can stop the poll and launch the answers. So 55% have gone for cardiac. So I think Dr. Jaymeena, can you tell us the answer to that?
So let's move on to the staging of AL amyloidosis. AL amyloidosis is being staged by various models. One of the most important model is Mayo 2012 model, which includes 3 factors. One is the troponin, cardiac troponin T is being included. We can also include cardiac troponin I with a value of less than 0.1 nanograms per liter, and NT-proBNP value of 1800, and the difference between free light chain involved minus uninvolved is more than 18. If there is 1 risk factor, you stage it as 2 risk factors stage 3, and 3 risk factors stage 4. Why do you want to stage? Let's see what happens. So this is the NT-proBNP progression at 6 months. So if there is a 30% reduction in NT-proBNP, at least a 300 nanogram reduction, the survival at 48 months can be predicted. So if there is no reduction, this will be the curve that goes. So basically, the stratification for AL amyloidosis is basically based on cardiac biomarkers. So in our patient, he had a troponin I was 0.05, NT-proBNP was just 610. Only the involved to uninvolved ratio was 100. So he was in stage 2. Only the 1 risk factor was present. So for this patient, we had given him Cybor-D, and it was initially weekly injection for 6 months. After that, once in 2 weeks for 1 year, followed by DEXA and injection both for once in 3 weeks for a year, and currently on injection bortezomib every month, and is monitored by urine PCR and SPEP and free light chain assay once every 3 to 6 monthly. So on last follow-up, this patient had normal kappa chain levels and the ratio was also normal. And urine protein creatinine ratio had dropped from 5.5 to 0.45. And so the treatment of AL amyloidosis includes the ideal treatment is the daratumab along with Cyborg. Basically, it is being studied up to stage 3A disease, that is extreme cardiac involvement of the last stage where there are 3 risk factors has not been studied, but the addition of daratumab to Cyborg actually improves organ response, organ function, overall survival. So how to actually monitor the response in MGRS? Sometimes we might not even have the clone, sometimes we might not even have the monoclonal protein in urine or serum. So then it is basically the kidney response what we have to check. It is like if you have a complete response, the urine PC ratio comes to 0.2 and it's a very good partial response. It is more than 60% reduction. Partial response is 31 to 50 and no response if it is less than 30% reduction proteinuria from baseline. So our patient had a very good partial response. So as soon as you get a patient with AL amyloidosis, we have to evaluate whether this patient is an ideal candidate for stem cell transplantation. If he is not eligible, we have to follow the DARA Cyborg for 18 months and then monitor. Whereas if the patient is eligible, after 4 cycles, we can actually plan for early stem cell transplant, or we can give another 18 months of chemo, and then if it is progressing, we can plan for a stem cell transplant. And there are various criteria to include the patient in stem cell transplant, which will be discussed later. So let's see.
Dr. Jaymeena, just before we go ahead, just a little bit about amyloid, which I'd like to ask Dr. Shinto.
Okay.
So, because amyloid is probably the most important one. Most of us see amyloid more than any other thing. So we need a little bit of more knowledge in that. One is that, would you start DARA-based therapy in all patients? Second thing, most of us, when you see cardiac involvement, we immediately ask for a dismal prognosis. So that is one of the things. But one more thing I want to ask is, supposing these patients do well on DARA therapy and they go into complete remission and all that, do they really need HSCT? In modern therapy, do they need a stem cell transplant, or is the DARA-based therapy enough? Does HSCT add value to that?
Okay. So DARA, the first line recommendation, Mayo Clinic only gives out all the recommendations. So say DARA is the standard of care, DARA Cyborg, that is the quadruplet therapy. So the problem with the DARA is the cost. So the cost of one vial of, now they have relatively came down on the pricing. Even the last week they had some more support, that is 1+1 support. So one vial will cost me around 2.25 lakhs. So I have to do DARA every weekly into 8 weeks for the first 2 induction, first 2 cycles. So that itself will cost me like, even if I get 1+1, that will be around 9 lakhs for 8 doses. Afterwards, I will move on to consolidation, which DARA will be dropped to once in every 2 weeks. So that won't be at 1+1. That is, they place at 2+1. So anyway, I'm looking around say, so we double it also. So maybe around 25 lakhs I have to spend on daratumumab. So if many of them are not affording, but there are people who ask for DARA. Presently, I have, I think, 6 patients on daratumumab, only on daratumumab. So myeloma, first line myeloma also we give daratumumab. So barring the cost, DARA is an excellent drug, because with DARA Cyborg, even in the Andromeda trial, they had a increment of over around 28% increment in the PF, means the response ratio, with DARA adding on to the conventional Cyborg. We won't prefer lenalidomide or IMiD-based treatment on the first line, because that adds to the toxicities, and they have to have some amount of renal dose reductions, especially lenalidomide and all. So DARA Cyborg holds the standard. If not, we go with Cyborg. So if we are using Cyborg, then if the cardiac part is either responding or means at the time of transplant, if I can take up for a transplant, post induction Cyborg, I can convince them for a transplant. But with DARA, I prefer not to do. If they are getting at least a VGPR or more, I might continue with the DARA. Even I can do a maintenance DARA of monthly once if the costs are permitting. If not, I do transplant because transplant is cheaper for me than DARA. And cardiac, since you mentioned, this patient was labeled as an HOCM, but part of it is part of the amyloid deposits in the cardiac because it was labeled as it was a heart failure with preserved ejection fraction, restrictive cardiac physiology. Because he's been going on post-provilar for this cardiac issue many places. But once his proteinuria ensued, then only the diagnosis came. Now we are not bothered about the heart. So that's what I would say. But it's not this because definitely rather than kidney, cardiac parameters are placed of utmost importance in the prognostic significance. So that's my take.
I think Jaymeena, you can do the second patient. I think we'll finish off in 5 minutes or something for this patient.
Okay, sir. Okay.
Okay.
So this patient 2 was a 66-year-old male, was a diagnosed case of diabetes mellitus. He had an old CVA and he was on clopidogrel. And on regular follow-up, his creatinine was just 1 in February 25. He was admitted in October 25 with presentation of generalized edema, oliguria, dyspnea, and newly detected hypertension. And he had a history of fever 2 weeks back. And on presentation, he had vasocrists, high blood pressure, and he had very severe renal failure at presentation itself. His creatinine was 5.8. His hemoglobin was just 9.5, which dropped to 6.6 during hospital stay. He had 3+ proteinuria, microscopic hematuria, and hypoalemia. So we also thought of some thrombotic microangiopathy going on because of the hemolysis, but there was nothing in the smear. And we did the other investigations for rapidly progressive glomerulonephritis. Only ANA was 1+, ANA profile was negative. The rest of the markers were negative. And this patient developed oligonuria within few days. And we initiated him on dialysis. We gave him methylprednisolone and followed by oral Vislon. With diuretics, his urine output improved to 600 ml. And after a week of holding clopidogrel, we subjected him to renal biopsy. The clinical diagnosis was RPGN with dialysis requiring renal failure. So renal biopsy actually showed a lobular accentuation with mesangial and endocapillary hypercellularity with neutrophils in the tusk and focal thickening of capillary walls. And IF showed IgG 3+, C1q and C3 along the capillary walls. And kappa was positive and lambda was negative. So with this, the diagnosis was MPGN pattern of injury with monotypic immunoglobulin deposits. So it is to rule out cryoglobulinemia, immunotactoid glomerulonephritis. So it was very evident that it was a PGN-MID, but to call a PGN-MID, we have to rule out immunotactoid or cryoglobulinemia. So for which we actually require electron microscopy. And we searched for monoclonal band in serum. SPEP was negative. Free light chain was also negative. And bone marrow aspirate showed only 2% plasma cells. And when subjected bone marrow to immunophenotyping, we could actually see a very, very small amount of plasma cells, which was actually picked up in flow, and a very small monoclonal population plasma cells. There was just 0.06% clonal plasma cells. And meanwhile, the electron microscopy reports came, which actually showed mesangial and subendothelial electron dense deposits without any substructure. It was subendothelial, few were even subepithelial without any substructure. So with that, the final diagnosis was PGN-MID with kappa and IgG. And there was no monoclonal protein in serum, and flow cytometry of bone marrow showed a very small plasma cell clone. So the term PGN-MID was first proposed by Nasser in 2004. Typically, patient presents with proteinuria, hematuria, and abnormal renal function, and only 30% have detectable clone in blood, urine, or bone marrow. And histologically, most of the times it is MPGN pattern of injury. And the incidence of PGN-MID is 7 times lower than AL amyloidosis and 2-fold lower than the MIDD. And average age of onset is 55 years. And usually PGNMID is less likely to develop hematological malignancies. But we have to keep a watch of these patients that they might develop CLL or B-cell lymphomas or smoldering multiple myeloma in long-term monitoring. So with that, let's go to the poll 6.
Yeah, I think it's a simple poll. What type of IgG subclass is commonly associated with PGNMID? Can launch the poll now? Is this IgG 1, 2, 3 or 4? Next time, please launch the poll. Yeah, so you can launch and can give some 10 seconds for the poll. Yeah, can stop the poll and announce the results. I think people have been listening to your presentation because most of them have got 38% have got the right answer. Okay, carry on.
So it is the IgG3 which is most common. 50% have IgG3 with kappa monoclonal deposits in PGNMID. Usually it is IgG3 constitutes 4 to 8% of the total serum IgG, but it has got a large molecular mass, and because of that it's restricted in the glomerular filtration barrier. And another property is it self-aggregates in FCC with FCC interaction, and moreover it causes C1q immobilization. Because of this, it can activate classical complement pathway after deposition in the glomeruli. And the pathological diagnostic criteria for PGNMID is the light microscopy. You should have a proliferative or a membranoproliferative pattern or an atypical membranous pattern of GN. And IF should contain glomerular monotypic deposits of IgG3 usually, and very rarely the other forms. And electron microscopy, you should just get a conventional electron dense deposit without any organized deposits. And clinical, there should be even absence of laboratory and clinical evidence of cryoglobulinemia. So patient 2, we haven't done a IgG isotyping, and we haven't done a urine immunofixation. So PGNMID is usually 20% of them progress to ESRD. The most important problem is that almost 80% recur post-transplant, and 86% of them recur within 3 to 4 months after transplantation. And MPGN type of injury is the most common, and even in transplant biopsies, and nearly 50% of the patients experience transplant failure within 3 years. So treatment of PGNMID relies on identifiable B or plasma cell clone. So what happens if there is a clone? If there is a detectable clone, well and good. It's very easy. So depending on the clone, whether it's B cell, we can give them patient with rituximab, cyclophosphamide, or dexa. If it is a plasma cell clone, you have the Cyborg. If there is no clone, then you have to go with the type of M protein in the blood or urine. So if there is an M protein detectable, well and good. You should see whether it's an IgM or a non-IgM protein. If it's a non-IgM, treat as VCD, treat with VCD, or IgM, it is either RCD or bendamustine rituximab. So the only problem comes when there is no detectable clone or no detectable protein in blood or urine. Then we should actually see the patient's kidney biopsy, whether there is acute or subacute kidney injury with a proteinuria of more than 1 gram per day. If it is there, then you should type the isotype of protein deposit in kidney. Then see whether it's IgM or non-IgM. This IgM, manage with RCD or RD, or non-IgM, we have to go for a VCD regimen. So if there is no subacute or acute kidney injury and proteinuria is less than 1 gram, we'll plan conservative treatment with RASI and other antiproteinuric measures, and see whether there is a proteinuria reduction of more than 50%. If there is no proteinuria reduction, whether to treat this patient or not should be a shared decision with the patient. If there is a reduction in proteinuria, just continue with the conservative management. So let's launch the poll 7.